How do we treat head injury patients? Head injury patients, as we know, is an emergency. Hence, a quick history and clinical examination is paramount importance. Why is history importance? Because the mechanism of injury will help us find out or suspect trauma or even multiple traumas. For example, high velocity injury in traffic accident will indicate us there could be spinal fractures, there could be intracranial hematomas, and associated injuries are common in high speed injuries. And alcohol consumption, as we saw, is about 15 to 20% in India. Alcohol complicates head injury in more ways than one. Because alcohol decreases cognition, it interferes with evaluation of GCS, the detail of which we will know in subsequent slides. Leads to more severe injury because the reflexes are lost and the person's ability to protect himself from fall decreases, leading to more severe injuries. Chronic alcoholics have liver dysfunction, which have a role in healing, which leads to delayed recovery. Coming to Glasgow Coma Scale, which was formulated by Brian Jennett and Graham Teasdale in the University of Glasgow, hence named Glasgow, and which has three components: eyes, verbal and motor, properly named E, V and M. Here I want to mention that motor response is more important than eye or verbal, and more important in the verbal is the best verbal response, and in the motor also best response is taken into consideration. What is best response? If you examine the patient for about 5 minutes, doing multiple examination, if you have more than one finding, you take the best response into account while mentioning Glasgow Coma Scale. For eyes, it can be spontaneous eye opening and a normal person is 4. To verbal commands is 3, to painful stimulus is 1, and if they do not open in any case, it's called 1. To painful stimulus means only sternal rub or compression over the ear lobule. Pinching and pricking is prohibited. And the pain stimulus has to be central, like axial, forehead and sternum, and to avoid limbs to give pain. Coming to verbal response, normal oriented speech is denoted 5, which can be you and me, assuming we are normal. If the patient is confused, it can be 4. If the patient speaks few words but inappropriate to the circumstance, it can be 3. If they produce only sounds, it is 2, and if they make no sounds, it is 1. And we will come to intubated patients later. Motor response is 6 highest. If the patient is able to obey command, it is 6. If the patient localizes pain, is 5. To localize pain, you must make sure that the patient is able to move the limbs, and if the patient is paralyzed due to neck injury, you have to be careful in evaluating the motor response. Withdrawal or abnormal flexion is 4, and withdrawal we will rule out flexion. Withdrawal to pain is 4, abnormal flexion is 3, extension is 2, and no motor response is 1. Extension is also called as decorticate rigidity. Coming to special cases. If the patient had a severe head injury, was unable to maintain airway and was intubated, verbal response cannot be taken into consideration, hence we have to mention T. And coming to motor response, obeying command, this is generally people confuse between obeying command and motor response, and the MRC grading of the motor power. Remember, in head injury, motor power has no value. Patient should be able to obey command. The command should be simple and discrete and should not be what the patient is already doing. For example, a semi-conscious patient may be partly opening eyes, so asking him to open eye will be dubious. Patient may be spontaneously moving one or two more the limb, so asking the patient to move the limb again will become dubious. So there should be discrete orders like show 2 fingers, blink the eye twice, show the tongue, in which the discrete response can be evaluated. To make sure that the patient, motor response is evaluated adequately, we must make sure that there is no cervical spine injury and paralysis. If you suspect a cervical cord injury, you should use orders like show me your tongue, blink twice. And when there is no motor response, it is 1. A GCS of 15 is considered as normal conscious oriented patient, and a GCS of 3 is considered comatose. The head injury can be divided into mild, moderate and severe based on GCS scale. Now coming to few aspects of the presentation of patients in head injury. Patient can be said to have concussion, which is defined as altered mental consciousness as a result of closed head injury, which is usually mild. It is not necessary for the patient to be unconscious at the time of injury, and patient may subsequently become unconscious or confused. Patient may present with amnesia or confusion. In both cases, it is called concussion. Patient may be lethargic, distractible, forgetful or slow to react. Gait disturbance or incoordination may also be seen. And coming to post-concussive syndrome, it's a vague term used to describe all the outcomes of the head injury in the recovery stage. Patient may present with seizures and few other symptoms. Seizures occurs about 10 to 15% of cases, which can be general tonic-clonic seizures or focal seizures. The seizures themselves will lead to more unconsciousness, thus complicating the evaluation of head injury. Then immediate seizures is of less importance. That is, if the patient had seizures immediately after injury at the site of trauma, it is less important than if the patient had seizures at a later time. Then examination. Before we go to examination, I would like to point out 3 things. When you ask a history of head injury, you must take a quick history. Hence, practicing it will help. The key factors to ask for is history of loss of consciousness, history of vomiting of more than 1 episode, history of nasal or ear bleed, or history of seizures. Presence or one or more of these will indicate substantial head injury. Coming to examination, if the patient is intubated at the scene, history may be obtained by bystanders to know if the patient was moving 1 or more limbs before intubation. First, ATLS is more important in head injury or any injury or polytrauma for that matter. Then we administer the GCS to identify the severity of head injury. Primary survey examination to rule out large laceration, obvious fractures, obvious exposure to chemicals, obvious large laceration, obvious dismembering, and injuries which may be immediate risk to life. Seeing the pupils and mentioning them in millimeters is more important. We should check both pupils and measure them with millimeters, and this can be done with constant practice. Why is pupils more important? Uncal herniation, as we saw in the previous image, compresses the third nerve, compromising the parasympathetic supply to the pupil, which is by the Edinger-Westphal nucleus. And unopposed sympathetic activity produces large pupil and fixation and dilated under continued compression. Hence, if one pupil is dilated, it is pertinent to assume that that side of the brain or that side of the brainstem had severe compression due to head injury, which in turn means that side of the brain has severe head injury. If both the pupils are sluggishly reactive, it is to be assumed that the patient has considerable head injury, and if the patients are fully or mid dilated and non-reactive, then it must be assumed that the patient has had severe head injury. Examination of the head and neck and secondary survey with focal deficits should also be done once the patient is stabilized. Now, how do we treat patients with head injury? The general terms are A, B, C, D, E, A, B, C, D and E. Maintaining of A is most paramount, then breathing, establishing an airway and establishing breath rate is most important, then establishing circulation is most important. These 3 together are to ensure adequate cerebral perfusion in order to prevent secondary injuries. Then we check the disabilities in the form of weakness of 1 or more limbs, disability in the form of spine injuries, and exposure to chemicals or exposure to toxic agents is also used to be done. Coming to breathing, ATLS guidelines address a fundamental priority. As I said, why ATLS is important, why airway and breathing is important. because uninterrupted perfusion to the brain with oxygenated blood is especially important after head injury. As we saw, there is increase in intracranial pressure, and thus we have to maintain cerebral perfusion pressure. Hence, to either decrease increased intracranial pressure, or we have to increase the mean arterial pressure. And there is a concept of Monroe-Kelly doctrine, which states that what we learnt earlier, that skull is a closed box containing brain, blood through the vessels, and CSF. Any increasing or addition of a volume has to come at the loss of blood or CSF, as brain is incompressible. If it goes beyond a point, there is leading to herniation of the brain, leading to death. Then, hence, securing an airway, breathing, and attaining adequate circulation is most important, referred to as ABCs of trauma.